Good day and welcome to this video of a focused two-dimensional echocardiographic examination. My name is András Nikovic. I'm an intensivist at the Mater in Brisbane. Real-time echocardiography allows the assessment of cardiac morphology, function and pathology. Echocardiography is very operator dependent. Therefore, it is important to standardize views, images, and measurements, both for accuracy and reproducibility. The heart is hidden behind bony structures and it's covered by air-containing lung tissue. Recall from the basic physics lecture that ultrasound is almost completely reflected on air soft tissue interface as well as on bone soft tissue interfaces. We need acoustic windows to develop a series of standardized views of the heart. The parasternal window is located on the left-hand side of the sternum. The apical window is where the apical impulse is maximal, or around the left fifth intercostal space in the mid-axillary line. The subcostal window is near the midline in the subxiphoid region, and the suprasternal window is where the suprasternal notch is located. Right parasternal and right apical windows, shown in blue on the image, are used to investigate certain conditions like congenital abnormalities. Imaging planes are described the way they transact the heart itself. The long axis plane is parallel to the long axis of the heart. The short axis plane is perpendicular to the long axis plane. The four-chamber plane transacts the heart from the apex to the base, showing all four cardiac chambers. The following terms are used to describe transducer maneuvers. Movement refers to actual movement of the transducer. Tilting refers to up and down movement of the transducer tail. Angulation is the side-to-side movement of the transducer tail. Rotation refers to twisting of the transducer. This can be clockwise or counterclockwise. Every ultrasound transducer has an image index marker. This can be a groove, a button, or a light. By convention, the image index marker indicates the right side of the image display, shown with the red dot on this image. Echocardiographic examinations usually start with the parasternal position. For this, the patient is placed in steep left lateral position, with the left arm extended and placed over the head. This position will drop the left lung away, and the heart will fall from behind the sternum, and the intercostal spaces will be maximized as well. In intensive care, often it is not possible to move the patient due to hemodynamic instability. This will only provide suboptimal images. We're using the parasternal acoustic window, and the transducer is placed in the third, fourth or fifth intercostal space to the left of the sternum. The transducer is perpendicular to the chest wall. Image index marker is rotated to 11 o'clock. This is the parasternal long axis view of the left ventricle. First structure encountered is the chest wall, and the anterior wall of the right ventricle is immediately behind. The right ventricular cavity is echo-free. The proximal aortic root is seen as two parallel lines. Two of the three aortic valve cusps are visible in this view. More anteriorly is the right coronary cusp, whereas the non-coronary cusp appears posteriorly. The mitral valve leaflets with the subvalvular apparatus are well visualized in this view. The anterior mitral valve leaflet appears longer than the posterior mitral valve leaflet. The subvalvular apparatus of the posterior mitral valve leaflet is visible on this image with the posterolateral papillary muscle and chordae tendinae. Focusing on the left ventricle now, we can see the basal and mid segments of the interventricular septum and the posterior or inferolateral wall. Thickness of these walls should not exceed 1.1 cm in systole. The LV cavity appears echo-free. The LVOT is bounded anteriorly by the intraventricular septum, posteriorly by the anterior mitral valve leaflet. Behind the ascending aorta, the left atrium is visible. The circular structure posterior to the left atrium is the descending aorta. If we drop the depth slightly, the above-mentioned structures are clearly visible. Observe the ascending aortic root with the right and non-coronary cusps of the aortic valve. Occasionally, the coronary sinus is visible as a smaller circular structure right anterior to the descending aorta. For measurements, it is important to correctly identify parts of the cardiac cycle. This can be timed according to deflections from the displayed ECG, where systole takes place from the Q wave to the end of T wave. However, mechanical events are slightly delayed, lagging behind electrical events, so it is advisable to use valve movements to time events of the cardiac cycle. End diastole is when the mitral valve closes. Zoomed in image of the aortic valve showing structures of the proximal ascending aortic root and aortic valve. The aortic valve leaflets must be thin and unrestricted in their motion. This image is used to measure the LVOT diameter as well. In this zoomed-in image of the mitral valve, both mitral valve leaflets should appear thin and they should be unrestricted in motion. For the parasternal long axis view of the right ventricular inflow tract, the transducer stays in the same position. We just have to tilt the transducer inferiorly and angling it medially. That is, the probe will look toward the patient's right hip. Minor adjustments might be necessary to obtain a better image. We can move the probe slightly more laterally, or a slight clockwise rotation might help as well. Structures identified in the parasternal long axis view of the right ventricular inflow tract are the right ventricle and the right atrium. These are separated by the tricuspid valve. The anterior and posterior leaflets can be visualized from this view. The IVC draining into the right atrium is commonly seen. Occasionally, the coronary sinus can also be seen draining into the right atrium. A persistent Eustachian valve or IVC valve may be occasionally seen. In this zoomed-in image of the tricuspid valve, the leaflets should appear thin and they should be unrestricted in their motion. Next view is the parasternal long axis view of the right ventricular outflow tract. The transducer still stays in the same position as the parasternal long axis view of the left ventricle. However, now we're going to tilt it superiorly while angulating it laterally. That is, the transducer is directed towards the patient's left shoulder. Minor adjustments might be necessary by moving the transducer slightly laterally or rotating it clockwise. This view visualizes the entire RVOT. Two of the three pulmonary valve leaflets are visible. The proximal main pulmonary artery is well seen as well. Occasionally, the bifurcation into right and left branches is seen. On this image, the right pulmonary artery is visualized. In this zoomed-in image of the pulmonary valve, the leaflets are thin and they are unrestricted in their motion. Here, the main pulmonary artery with bifurcation is well seen. Both the right and left pulmonary arteries are well visualized. Moving on to the parasternal short axis views, the transducer stays in the same position that is used for the parasternal acoustic window. However, we're rotating the probe 90 degrees clockwise into the 1 o'clock position. The first image that we obtain from the parasternal short axis views is at the level of the aorta and the left atrium. The aorta appears as a circular structure in the center of the image. All three cusps are visualized in this view. That is, the right coronary cusp, left, and non-coronary cusps. The left atrium is immediately posterior to the aorta. The right atrium appears to the left-hand side of the image. The interatrial septum separates the two atria. The septal and anterior leaflets of the tricuspid valve are visible to the left-hand side of the image. The RVOT crosses anterior to the aorta from the left to right, and two of the three pulmonary valve leaflets can be seen on the right-hand side of the image. On this zoomed-in image of the aortic valve, a Y-shaped pattern is obvious when the valve is closed. If we zoom in on the pulmonary valve, we can observe the pulmonary leaflets snapping open in systole. This is the zoomed-in image of the tricuspid valve. The anterior leaflet appears to the left-hand side of the image, while the septal leaflet appears medially. Take a moment to identify all of the above mentioned structures. You can even pause the video for this. The next image from the Parasternal short axis view series is the Parasternal short axis view of the left ventricle at the mitral valve level. Portions of the right ventricle appear anteriorly, whereas the LV appears posterior and it is circular in shape. During systole, the LV walls thicken. The anterior mitral valve leaflet appears anteriorly and the posterior mitral valve leaflet appears posteriorly. Where the leaflets meet are the commissures, and they are named corresponding to the papillary muscles. The anterolateral commissure is on the right-hand side of the image, while the posteromedial commissure is to the left. Normally, the leaflets will appear thin and unrestricted. This is the next image in the series of parasternal short axis views at the level of the papillary muscles. The LV is transected at the level of the papillary muscles. Anteriorly, the RV is visible. The papillary muscles are displayed on either side of the left ventricle. The anterolateral muscle is seen around 3 to 5 o'clock, while the posterior medial is somewhere between 7 and 9 o'clock. To display the parasternal short axis view of the left ventricle at the apical level, we have to move the transducer laterally, and we also have to drop a rib space. The LV appears in the middle of the image. The LV appears as a small rounded structure with an echo-free cavity. Note the torsion movement of the LV apex. We're moving on to the apical position now. To obtain the apical images, the patient remains on the left side with the left arm extended. If the apical impulse is palpable, the transducer is placed on or near it. Otherwise, we select a spot in the fifth intercostal space in the mid-axillary line, with the probe looking superiorly directed towards the patient's head. For the apical four-chamber view, the image orientation marker is rotated to the 3 o'clock position. The apical four-chamber view allows visualization of all cardiac chambers. The cardiac crux or cross is located in the center of the heart and is formed by parts of the interatrial septum and the interventricular septum. Both AV valves are well visualized. The mitral valve is on the right-hand side, shown red here. The smaller posterior leaflet is arising from the lateral border, and the larger anterior leaflet arises from the medial aspect. The tricuspid valve leaflets can be seen originating from the right AV ring. The four cardiac chambers, that is the LV, RV, left atrium and right atrium, are all echo-free. Between the two ventricles there's the interventricular septum. while the two atria are separated by the interatrial septum. Pulmonary drainage into the left atrium can be appreciated from this view. On this image, we can see the right upper pulmonary vein and the left lower pulmonary vein. The descending thoracic aorta appears as a circular structure along the lateral margin of the left atrium. The right ventricle appears triangular in shape with a cavity about half the size of the left ventricle. The lateral free wall of the right ventricle can be assessed from this view. The left ventricle appears as a truncated ellipse with the anterolateral wall, inferior septum, and apex visible. For the apical 5-chamber view, we have to tilt the transducer anteriorly until the left ventricular outflow tract and proximal ascending aorta are visible. The proximal ascending aorta and LVOT constitute the 5th chamber. The LVOT, proximal ascending aorta and the aortic valve leaflets are visualized on this image. By rotating the probe counterclockwise into the 1 o'clock position, we can obtain the apical 2-chamber view. In this image, we can identify the LV and LA separated by the 2 mitral valve leaflets. The descending aorta is behind the left atrium. The apical 2-chamber view is especially important in assessing the true anterior wall and the true inferior wall of the left ventricle. Make sure that you're imaging the whole LV, as foreshortened images might miss important pathology. Like on this image, an LV apical aneurysm would have been missed with the foreshortened image. For the apical long axis view, the probe stays in the same position, but we have to further rotate it counterclockwise into the 12 o'clock position. Structures visualized in the apical long axis view include all those described in the Parasternal long axis view of the left ventricle. The structures seen here are the right ventricular and left ventricular cavities, as well as the left atrium. The proximal ascending aorta with 2 cusps of the aortic valve is seen here. And lastly, the anterior mitral valve leaflet and the posterior mitral valve leaflet are both seen on this image. In the ICU, sometimes the only position that gives acceptable images is the subcostal position. For this, the patient is supine. If awake, they slightly bend their knees to help release tension of the abdominal muscles. On inspiration, the cardiac structures will descend, making it easier to image them. The transducer is placed in the subxiphoid position. For the subcostal long axis view, the image marker is at 3 o'clock And for the subcostal short axis view, marker is rotated into the 12 o'clock position. So for the subcostal 4-chamber view, the transducer is slightly to the right from the subxiphoid position, and the image orientation marker is held at 3 o'clock. The liver is the first structure transected by the ultrasound beam. The two atria are separated by the interatrial septum, while the two ventricles share the interventricular septum. Both the interventricular septum and the interatrial septum can be assessed in their entirety from this view without dropout. Both mitral valve leaflets and 2 of the 3 tricuspid leaflets are identified on this image. For the subcostal short axis view, the transducer is in the subxiphoid position with the image marker in the 12 o'clock position. This image is similar to the parasternal short axis view with a 90-degree location clockwise. Most proximal to the probe is the liver. The LV appears as a circular structure with the 2 papillary muscles. On this image, we have the LV at the level of the mitral valve. The anterior mitral valve leaflet appears to the top and right of the image, while the posterior mitral valve leaflet appears to the bottom of and left of the image. The subcostal short axis view at the right ventricular outflow tract level will show a similar image to the parasternal short axis view. The aortic valve appears in the center of the image. The RVOT is situated in between the tricuspid and the pulmonary valves. Portions of both the left and right atrium are seen on the left-hand side of the image. If we're angling the transducer towards the patient's left, we'll obtain an image of the abdominal aorta. By sweeping the transducer from the midline toward the right, we'll find the IVC. The inferior vena cava can be seen draining into the right atrium. Respiratory variations in IVC diameter are important measurements in ICU echocardiography. Thank you for listening to this lecture. Goodbye.